Good morning. One of the most challenging elements of any biological problem is defining the outcomes, the phenotypes, the definitions that we use to describe what it is that we're actually measuring. And this is an area in particular in medicine that has been, I would argue, somewhat neglected over the last 100 years or so. In many instances, we're challenged by the fact that we're really working with relatively heterogeneous legacy phenotypes. And so in the next 20 minutes or so, I'm going to try and describe to you some of the rationale and the strategies for reimagining how we define phenotypes and choose carefully the phenotypes that we use as we move medicine into a systems level definition of the human biological journey. My disclosures are outlined here. Probably the most important from this standpoint are the funding from Verily, AstraZeneca, and Quest Diagnostics. I'll describe briefly some digital work that we're doing with Apple and Samsung and have done in the past with Microsoft. And then obviously companies which I have a personal interest, which are overlapping with this particular topic, include the four on the right. And perhaps the most important conflict is academic self-interest because, as I will show you, it's very difficult to really make sense of anything that you can't measure. In almost every aspect of medicine, of biology, phenotypes and disease definitions are rate limiting. Genetics allows us to get access to causality, gives us proximate points for intervention. But in reality, almost all of the genetics that has led to mechanism is very large, uniform, Mendelian size effects. And the reason for that is that those are assuming a etiologic homogeneity, that in a single family, in multiple generations, the same single defect must be present in order to be transmitted in this way. And as you'll see, one of the fundamental assumptions of genetics is essentially broken in genome-wide association studies. That's not necessarily a bad thing because I think those studies also allow us to get access to pathways. But what they do not do in a systematic way is give us mechanism. And I think that's quite important for us to remember, that that's really where genetics is at its core. Most useful. And there are many other things that predict outcomes depending on the timelines and the actual outcomes that you're wondering about. But the reality is that the majority of the small effect size phenotypes on the far right are not really capable of incrementally changing our understanding of the mechanism of a disease. Perhaps the most interesting thing in this diagram, which is present in almost every genetic talk worth its salt, is the fact that there is actually quite a large untapped area of unmeasured phenotypes or unmeasured phenotypes with modifiers, largely because of the fact that the modifiers themselves are not known or not used as a conditioning variable. And this obviously would require much more systematic collection of those data types, which has not really been done. It is also worth pointing out, and this is a diagram from Robert Plange and David Altshuler from many years ago, but others, including Matt Nelson, have replicated these findings to show that the larger the effect size, the larger the genetic effect size, the more likely you are to be able to get a drug modifying that biology into the clinic. And so what I'm going to talk to you about is really thinking about a very different strategy where we select disease subset target pairs. We actually build a platform that allows us to do this, to say we have a disease subset, we refine it sufficiently that it has relatively homogeneous etiology, and that allows us to begin to cross existing disease silos with new biology, to improve alignment with patient-level problems. Patients don't really care about population-level disease definitions. What they care about is what is going to happen to me over the next 5, 10, 30 years, and do this in a way that actually has a reproducible pipeline. And this would let us subset disease using phenotypes that actually are easily recordable, ideally, but allow you to discriminate between biologically distinct causes of the same final phenotype. And I'll explain in a few minutes what I think about it. But importantly, the goal of all of this, the goal of network medicine in general, is to begin to get mechanism at a patient level. And there are a number of ways that I think we can begin to think about doing that. So traditional disease definitions are really just a set of clustered observations and outcomes. As you might imagine from legacy understanding of medical history, a large part of what we have been left with are things that have a fairly short timeline between the symptom, signs, and the outcomes, because that was essentially what a single physician could do in the Middle Ages or even until the early 19th and 20th centuries. The bulk of this is pattern recognition. It's almost always post-presentation. People would show up with a problem. People would then follow that individual who had been identified and try and understand the outcomes. So in many instances, these were cross-sectional phenotypes. They were a limited number of outcomes, usually binary. You either got better or you didn't get better. And they were confounded by the fact that there was a huge amount of heterogeneity. As we've evolved phenotype predictors or endophenotypes, we've begun to recognize things in this yellow part of the curve, and this is actually not coincidentally a reflection of our approaches to looking at risk factors earlier and earlier in disease. And ideally, what we would be able to do is to follow those trajectories to understand how different aggregates of risk factors led to discrete outcomes. At the moment, we are still doing this in a fairly large population level resolution. And the main reason for that is the relatively modest number of biomarkers that we have, their remote relationship to the underlying biological outcomes. They're often discovered as a consequence of the very heterogeneity that we're worried about in trying to get at some form of biological and etiological insight. And importantly, the other thing that I think is fundamental in all of them is that they're really almost always driven by intuition, not by an unbiased methodology. So as a consequence of that, things like LDL, things like natriuretic peptide, things like abnormal autoantibodies, those are things that we often will interpret as if they are relatively uniform, but in many instances they're really quite late stage and emergent properties of an already failing biological network. The ideal thing that we'd really like to do is build this type of almost lifespan level trajectory of computable personal phenotypes. We'd really like to understand antenatally what's happening. I believe, given the fact that the genome is the only really unbounded data set, that a genome-based data schema is a good place to start. But what you'd really like to be able to do is monitor health and wellness and identify the very earliest deviations from this. And this would allow us to measure lifespan in a series of objective biological states. They would be individual, patient-centered, or person-centered. They would be both medical and non-medical. They would have real-time data that was capable of driving refined models for predicting a variety of outcomes and models that could be continuously updated. They would ideally also have a ton of metadata, and I think that would be one of the things that we should begin to think about as we're talking about how we can improve phenotypes going through the next 15 minutes or so. But those metadata could come internally. They could be metadata that we supply, or they could be metadata that are supplied by the clinical interventionists themselves during later stage disease. And so what I'm going to try and do to you is very briefly just describe the sorts of things that might be possible to do to build these types of computable phenotypes, but importantly do it in a way that I hope will illustrate the scope and scale of what might be possible if everybody was thinking about these types of approaches to resolving disease heterogeneity rather than iterating on the legacy phenotypes, which, as I hope to show you, may be really so low resolution that they make some of the other approaches that we have been using over the last decade or 2 decades inefficient and haphazard. This is just an illustration of the extent of the data gap. As a simple tool and mnemonic, I've listed two axes here. One is objective measurements and their scale, and the other one on the bottom axis, the orthogonal axis, is all of translational phenotypes, which for everything in all of medicine adds up to only about 12,000 phenotypes. That's the entire human phenome. So it's hardly surprising that we're not able to deconvolute even simple variation in the genome, far less the complexity of transcriptomics, proteomics, cell-cell connections, the connectome, the physiome, time dependencies that go from microseconds all the way through to 100 years or so, and all of that in the setting of a almost embarrassingly scant record of exposures. And this gap is really, when you look at it with other areas of endeavor in human activity, just profound, both with respect to the volume of data, the velocity of data, the variety of data, and the cost of the data that we collect. In almost every other setting, systems have evolved to use the output of the system as part of its intrinsic feedback loop for driving improvement. And we don't really do that in a systematic way in biomedicine. It's very much one and done, a very local and bespoke, almost artisanal approach to thinking about individual diseases. We were funded by the American Heart Association, by Verily Life Sciences, and by AstraZeneca, and subsequently by Quest, to really begin to think about how we moved in a systematic way from late-stage disease, which is what I would argue most existing risk factors represent. For example, on the day that you're diagnosed as a type 2 diabetic, 100% of individuals in the ARIC cohort had CT abnormalities in their coronary arteries. So the fundamentals of this approach were to move the granularity and resolution of what we're measuring into very early stages, and ideally understand those very first deviations from a normal functional state, a normal biological state. And that obviously requires you to be able to define that, first of all, and then to follow it longitudinally at a resolution that allows you to see deviations from it. So the approaches that we took to defining new informative phenotypes were that they would be selected for the desired outcomes. So instead of taking the traditional view of phenotypes, which is, again, not anybody's design fault, this is how they evolved over time in medicine, instead of taking the phenotype first and then trying to retrospectively work out what the predictors were with a really robust and computationally closed loop, it's possible to begin to select phenotypes that are associated with relatively actionable outcomes on a whole variety of timescales. Our goal was to focus on human biology in every clinical encounter, to take a very unbiased analysis of existing data types and begin to extract more information from them, and then to think systematically about evoked phenotypes with disease-relevant perturbations. And those disease-relevant perturbations may be things that are in the native sets of metadata, so nutrition if you're healthy and well, drugs if you're already being treated by a physician. But in addition to that, thinking much more broadly about the environment, about the microbiome, and about potentially scalable approaches to testing large numbers of evoked phenotypes. And the goal of all of this is computable biological transactions and outcomes. So there are lots of potential places that you might go. This was published in Circ Quality and Outcomes, but it was a paper that Rahul Deo in our group led, looking at trying to extract new information from existing data, the complete blood count, by looking at standard hematologic indices at a higher level of resolution, usually the primary morphometric output from the cytometers that are used for defining complete blood counts, was able to show that with a relatively modest amount of information content and a really rigorous amount of training and outcomes, it was possible to identify biomarkers that outperformed many of the existing biomarkers and were at least as good as any existing biomarker for cardiovascular disease events in a short, intermediate, or longer term trajectory. The same team also was able to reimagine how to think about echocardiography, so taking a completely agnostic view of echocardiography. Rahul's group had originally built a completely automated platform for echo interpretation and reporting. They subsequently went on, when we were working at One Brave Idea, to begin to look in a very serious way at taking completely agnostic echo interpretation to look for things that no human could identify, and to map those onto outcomes that were particularly useful in a clinical setting. So this is one where a single parameter was measured, ejection fraction as defined on echocardiography. These individuals who were in this cohort all had to have had a normal baseline echo, both by report and by automated analysis of ejection fraction. But they clearly had to have had an echocardiogram for some reason. Either they were being evaluated, or there were some other sets of symptoms or rationales for doing this. And what was done here was to train echocardiographic baseline phenotypes on heart failure with reduced ejection fraction within the subsequent 12 months. And when this was done, a single principal component was identified, which had a very discrete genetic basis. And when we subsequently modeled this at scale in the setting of a large number of cardiomyopathy mutants, we were able to show that this ubiquitin ligase is actually important for the trafficking of multiple different sarcomeric proteins. Importantly, this strategy also picked up other LV mass genes that had previously been seen in other settings, but with a very much larger effect size in the context of echoes that did not actually have any LVH at baseline. So it begins to tell you that there's a ton of information, even in the phenotypes that we've already collected, that has just never been extracted because we're relying on our personal intuition to be able to define those events that are important and to correlate them with outcomes, which obviously requires us to have systems that allow us to do this at the requisite scale. And until modern convolutional neural networks and the associated storage and compute were available, this was very difficult to undertake. What we'd really like to do is begin to think about classification by mechanism using orthogonal data. We want to deliberately go after phenotypes that are not present in the baseline canon of phenotypes, but add value, and do that not in a sort of generic way where they're in the middle of the dynamic range, not particularly scalable, have to be administered to individuals with relatively high pretest probabilities of the particular outcome that you're testing for, but actually much more likely to be phenotypes that are up in this far top right corner, where they have very high dynamic range, are cost-effective and highly scalable, and are almost completely mechanism specific. And so we set about trying to do this in a very systematic way. We've been collecting digital phenotypes for quite some time. We have previously published that it's possible to use very simple diagnostic measures that can be applied in the waiting room in a clinic to be able to define, for example, the subsets of cardiac amyloid based on echocardiographic abnormalities in a single, very short audiometry test. It's possible to classify ischemic and non-ischemic cardiomyopathy, dilated cardiomyopathy, based on stride length on your way into the echocardiographic suite. And then this was work that was actually not done by us, but done by Jeff Safetz, one of my colleagues, looking at buccal cellular data in individuals who have arrhythmogenic right ventricular cardiomyopathy, and showing that the junctional and nuclear abnormalities present in the right ventricle are also present in the skin. So you can imagine, for things as simple and widespread as coronary heart disease, there are lots of approaches that you might use. Google has recently published retinography that allows you to predict cardiometabolic outcomes. We wait until the macrophage accumulation with loaded lipid is visible to the naked eye. There have been documented abnormalities of the response to a nutritional load in terms of vasomotor responsiveness for decades that we haven't really implemented. And then perhaps the best metric for predicting risk in coronary disease is the response to the initial dose of LDL. That turns out to be a very robust predictor of outcomes in every statin trial that's ever been undertaken. So this gives you a sense of where we might go for the measurements and the types of tools and technologies we're looking at. We need to think, are there ways also of getting deeper and more robust approaches to the underlying biology? One of the things we recognized when we were looking at the complete blood counts was there was a huge amount of information, over 90 raw parameters available based on morphology in a standard clinical cytometer. It's possible to assay 100,000 cells in a couple of minutes. And so we began to build this approach, which would take primary human cellular profiles, add chemical or physical or genetic perturbations, and then look at those same profiles in individuals at scale to be able to build a new massively multidimensional phenotype map, and then try and understand if there were actually latent phenotypes that might represent important mechanistic intermediates in common disease and help us differentiate, as I said at the start, the different types of common disease. So this is very straightforward. It's self-phenotyping directly in a clinical workflow. I would argue that one of the reasons cancer has been so successful at getting at mechanism is they've worked at the level of cell biology. But here you can see, again, this is just shown two different patients, both with the same small molecule. This is butyrate for the sake of argument. And you can see here in the upper panel, no obvious change from baseline. In the lower panel, you can see the emergence of this subset of cells in the neutrophil class that has essentially appeared as a result of a morphometric distortion. And when we did this, we mapped it on these phenotypes. We did this at substantial scale. We mapped them onto a high-resolution machine learning-driven phenotype map from the electronic data warehouse in a large electronic medical record with about 1.5 to 2 million records, depending on the phenotypes. This is the Mass General Brigham record. And then we were able to very efficiently do genetics because these are large effect sizes that have simply been missed and are associated with common alleles. Nice thing about this approach is that we're able to take these cellular data, the genomic data, stratify disease by subsets, but importantly also externally validate these data using the genetics as a means of predicting outcomes of a discrete nature in large biobanks like the UK Biobank. And this allows us to confirm that the endophenotypes that we've measured are valid because they've been missed in existing GWAS data sets, but when we identify the genes and loci involved, we're able to predict the requisite outcomes in these large population data sets. The nice thing about this is it's completely assay agnostic. You can imagine using any benchtop assay with a small molecule profile, but you can also imagine doing the same thing in vivo with standard meals and wearable data. And the important thing is a quantitative phenotype with a substantial dynamic range and a set of perturbations that are empirically important for defining latent variation. This work was subsequently published in Nature Genetics, and you can see a lot of really powerful predictions, particularly in the cardiometabolic space, which is where we started. Large effect size, both positive, i.e. Risk predictions of sets of outcomes, or negative, low risk of a particular set of outcomes, along a whole host of phenotypic axes. With only 25 or 30 different perturbations, we're able to generate hundreds of new phenotypes with Mendelian or pseudo-Mendelian effect sizes. A couple of examples. This was one that was actually done in a automated microscopy platform where we used ligands for particular channels or blockers for particular channels, either in a group of undifferentiated type 2 diabetics. We were able to show there was a subset of diabetics, it's not easy to see in this slide, who had a very potent response to the piezo-1 activator, YODA-1, This was not surprisingly mapped to the Piazza-1 locus. There's a common variation in this locus that dictates the extent of responsiveness to this small molecule. But importantly, it was strongly correlated with deep vein thrombosis in diabetics. And in fact, when we did the cell biology in an animal model, we used the zebrafish for this, partly because of the fact that we have so many of these novel genes. We need a scalable biological in vivo system to evaluate them. And we were able to show that high blood glucose selects clones in the bone marrow that are very high Piazza-1 expressors. So this makes the individuals highly sensitive to mechanically induced venous thrombosis for a period of time after any prolonged hyperglycemia. This work was published in Science Translational Medicine in 2023. And the important piece of this is obviously that a Piazza-1 inhibitor is able to prevent this thrombotic phenotype. Similarly, there was another example, and obviously there are many of these, which you can see in the Nature Genetics paper, where we took undifferentiated cardiometabolic syndrome. You just had to have an abnormal lipid, blood pressure, or hemoglobin A1C that was not diabetic. And we were able to show that there was a subset of individuals in this group of patients who had a latent neutrophil longevity phenotype that was associated with strong and persistent inflammation in animal models, but in the clinic was associated with a very multifaceted latent disease atherosclerotic phenotype with rapidly progressive renal function, renal dysfunction, as well as peripheral arterial disease. And the genes in this situation were actually three common genes, two in a glycolytic pathway and one in the opposite direction in a fatty acid oxidation pathway, which led to increased glycolysis and reduced neutrophil apoptosis. Average survival benefit for the neutrophils was about 4 hours over a 24-hour period. But importantly, that leads to subclinical activation that when there is an intercurrent illness leads to an exaggerated inflammatory response and a reduced resolution of inflammation, as seen in these zebrafish experiments later on. The last piece I'm going to highlight here is that one of the areas, as I said at the very start, that we've really failed to include in any of our approaches to phenotyping is systematic collection of data across populations in a clinical setting. So every time somebody's exposed to a drug, understanding their individual response to that drug will give us really important information about their absorption, the drug's pharmacodynamics and pharmacokinetics in their body, but importantly also the mechanisms of their underlying disease. And so one of the things that we worked fairly hard several years ago, actually before we were funded by the American Heart Association, Google, or AstraZeneca, we built a platform that allowed us to systematize the management of clinical disease. And the way to do that was to virtualize a lot of the basic mechanics of drug titration and do it in a way where we were breaking down, parameterizing the diagnostic criteria for a particular set of disease, building a series of clinical transactions as biological operators to allow uniform process control, eliminate any artisanal complexity, build really robust data collection with fixed inputs and outputs. A nice thing about this approach is it also allows workflow redesign, but importantly, one of the primary rationales for it was to collect data on individual subjects at a very granular level, allowing you to characterize their biology and begin to build a closed-loop system. And this is exactly what this platform has been designed to do. You have a patient, you transact, typically using non-clinical personnel, but with the medication changes authorized by a licensed individual. Ultimately, this is the sort of approach that could be used for self-care, but importantly, it captures data that allow you to match patients to their optimal therapy based on prior responses to similar therapies. You generate novel biomarkers that are transactional, which is actually incredibly powerful when you're building closed-loop reinforcement systems. And then importantly, you also can begin to impact behavioral strategies that are important for the biology that we are studying. This allows us to continuously update treatment algorithms, but importantly, to update the profiles of the individual patients. And the goal here, as you can see, is to build, as we saw at the very start, computable definitions of wellness, health, and subsequently disease. To do this in a way that can be continuously optimized for the individual, so you have a very precise prediction of their trajectory over their lifespan. And importantly, that allows you to classify their disease in a very complete and discrete way, allowing you to subset not only the molecular basis, as we've described, or the in vivo physiologic basis with wearables and standard perturbations, but also importantly, the clinical outcomes based on therapeutic trajectories as well. The goal of all of this is to build foundation models that would be foundational in biomedicine. The most important element of this is also, I think, merging the clinic and research and development phases so that human primary data collected in the clinic feed definitive training sets for new models, target identification using the techniques that we've identified, as well as many others that many of you, I hope, will identify. Building new therapeutics using the screening technologies that have been so successfully deployed in genetic diseases over the last couple of decades, and doing that in an accelerated way before returning to patient cohorts that have been defined based on the very metrics that you used to identify the targets, and that therefore we hope accelerating implementation. And the goal of all of this really is a much more rapidly optimizing biomedical system, hopefully one that approaches the types of timelines that are seen in many other industries in our experience. So in summary, I hope I've shown you that organ-specific static phenotypes are low in information content. Biomedical phenotyping is non-systematic by design. Most of the things we measure are legacy traits and redundant. There haven't been many new phenotypes, with the exception probably of tomographic imaging in the last 100 years or so. New phenotypes and diseases can be systematically discovered, selected for actual utility for the individuals, diagnostic, prognostic, or therapeutic, and rapidly exploited by design. We can build these into existing workflows. The goal is to do this in a way that allows you to extract the highest information content phenotypes that leverage current approaches while also building a future that integrates phenotyping with discovery and care. I'm going to stop there. I want to highlight two people who have made huge contributions in particular to this, Rahul Deo, Juan Diju. I should also highlight Max Hamilius, who was really the driver behind the cellular phenotyping, and then thank Ed Silverman and Joe Lascalzo for their efforts in building this exciting network medicine course. Thank you for your attention.